Good evening. Bonne soirée et bienvenue. My name is Mark Graham, and I'm the Vice President for Research and Collections here at the Canadian Museum of Nature. C'est un plaisir pour moi de vous souhaiter la bienvenue à cette soirée spéciale. I would also like to acknowledge that we are hosting this event on the traditional territory of the Algonquin people. On behalf of the Canadian Museum of Nature and Natural Sciences, I'm delighted to open this evening's innovative panel discussion about health as part of the Walrus Talks series. We've partnered with the Walrus for several years on these events that present thoughtful, provocative, and inspirational talks. Here at the museum, our CEO, Meg Beckel, likes to summarize what we do by saying that we're saving the world through evidence, knowledge, and inspiration. Providing a forum to connect, explore, and be inspired by different voices and perspectives is core to our mission. Open exploration of ideas informs our approaches to how we present our galleries, and exploration is central to the work done by our research centers in Arctic knowledge and in species discovery. That kind of research sets the very foundation for such a wide variety of other work by providing scientific names and classification for species, providing evidence for how closely these species are related to each other, and where you might find them, and how they relate to each other ecologically. Today, we have a growing appreciation for the link between humans and the natural world. Our actions impact the earth, and we increasingly recognize that nature and how we change our natural environments may affect our health at all stages of our lives, at times quite significantly. Well, the challenge then is to improve our understanding of the intricate links between ourselves and the world around us as advances continue in all areas of health sciences. And I look forward to hearing our distinguished speakers tonight as they unpack some of the big ideas in health care today. And before we do that, please join me in welcoming to the microphone Shelley Ambrose, the Executive Director of the Walrus Foundation and the publisher of the Walrus magazine.
Thank you, Mark, for that warm welcome. I am indeed Shelley Ambrose of the Walrus, and it's great to be back here at the Canadian Museum of Nature, one of the most storied and interesting institutions in the country. I'm honored that I sit on the jury here of the Canadian Museum of Nature Inspiration Awards, which is an awesome thing. And like tonight, you get to have a reception afterwards under the giant squid. I know it's not a squid. What is it really called? It's a jellyfish, the giant jellyfish that goes pink and yellow and green and blue. We're in love with the giant jellyfish. So this place, as Mark just said, has a rich history where we are standing, and this place that we are in has a very bright future, and the Walrus is actually all about the future. This optimistic project called the Walrus started almost 15 years ago. In fact, next year, 2018, is our 15th anniversary. Hello, Meg Beckel, CEO of the museum, who just walked in. Hi, it's okay that you're late, it's your house. Come on in. It's our 15th anniversary next year. Our job is to create forums for the Canadian conversation. One way we do that is by publishing the Walrus magazine. How many of you know about that? You're holding it in your hand. Everyone should have their hand up at this point. How many of you subscribe? Don't lie. You are my people. Those are my favorite people. See me afterwards, I'll buy you a drink. And another way that we create forums for the Canadian conversation are, of course, the Walrus Talks. How many of you have been to one before? Welcome back. And the new people? Let's welcome the new people. Yay, new people. Thanks for coming out. So for those new to us, yes, we have a magazine. Yes, we have the Walrus Talks. Yes, we have a website with daily journalism. But what we really are is a place for you to listen, share, talk, ideas for the future of our country and, in fact, the world. And in all things Walrus, you will find well-told stories on everything from politics to culture, environment, technology, and so much more. Everything we do is meant to spark a conversation. So you are here. Thank you for heeding the call. You are now Walry, all of you, and we know that's not a word, but we like it and we use it. And Walry have something in common. So even though you don't know the person sitting next to you maybe, what you have in common is that you tend to like to think about stuff and that you maybe subscribed, well, you do. You subscribe to the notion that your mind is like a parachute. It behaves nominally better when open. So life is complicated, and to understand these issues, we do things like the Walrus Talks. A walrus is a large Arctic, smelly, hard-to-ignore mammal. It has no wings. So the walrus is not left wing or right wing or any wings. There are no wings. We are an independent entity with no owners and no one point of view. We are a charitable nonprofit, we are national, and we have an educational mandate, which does not mean we are pointy-headed and boring. It just means that our journalism is fact-based, which we didn't think we used to have to say out loud. We thought the word journalism was enough, but no, it's fact-based, and we have real-life human fact-checkers designed to ensure the future of journalism is bright. We also have a training program at the Walrus, and our journalism and our training programs are supported financially by, of course, circulation, Paquito advertising, you understand, sponsorship, charitable donations, events like these, and our partnerships. And there's no way we could do the work we do without partners like McKesson Canada. We've been working with McKesson for several stellar years now. We love working with people who, like Walry, believe in supporting conversations that matter. McKesson is a true industry leader in technology, innovation, and health. They're in the business of better health for all Canadians. And to tell us a little bit more, please welcome McKesson's Vice President, Strategic Technology Solutions, Jean-Philippe Louin.
Thank you, Shelley, for the introduction. Thank you for joining us today at what promises to be a thoughtful and stimulating discussion. My name is Jean-Philippe Louin. I'm Vice President, Technology Solutions at McKesson Canada. McKesson Canada dates back to 1905 here in Canada. And we have a long history of partnering with governments in delivering value-based care, in creating efficient supply chains, but also in bringing innovations to Canadian patients. We are honored once again to be able to bring you tonight's discussion, which is focused on how different segments of Canadian society can help make our healthcare system more innovative, more efficient, and more sustainable. At McKesson Canada, we are proud to have introduced our Relay Health patient electronic record in Nova Scotia, in parts of Ontario, but as you will hear tonight, with the Cowichan Tribe First Nation in British Columbia. Implementing a province-wide healthcare solution isn't exactly brain surgery, but not far off. In Nova Scotia, we worked intensively with the provincial government to pilot Relay Health with 30 doctors and up to 5,000 patients. That test run taught us two important things. First, patients loved it. They love having access to their healthcare information 24/7 online. And second, and surprising in some cases, but the physician loved it too. It was integrated with their system, and it increased their capacity by up to 22% in some practices. That's the equivalent of adding 700 doctors province-wide in Nova Scotia. Thank you. I have my fans here. In short, using technology to empower physicians and patients can create enormous potential for our healthcare system. Following our pilot, the provincial government chose Relay Health as a solution for all of the Nova Scotia citizens, and we're deploying actively right now. Our 7 speakers tonight will each provide us with a unique viewpoint of the challenges and potential for healthcare in Canada. We will hear all about all kinds of interesting ideas and initiatives, and have the chance to collectively imagine a more sustainable and a patient-empowering health system. On behalf of McKesson Canada, I'd like to thank each of the speakers for tonight and the Walrus for putting this vital discussion together. And finally, I'd like to thank you all for attending. I think we're sold out tonight, and wish you a great evening. Thank you very much.
Thank you, and thank you to everyone at McKesson for making tonight possible. I also want to thank our national partners at Inspire, Shaw, and Shirk, and AMIA Aeroplan. They're with us everywhere we go, and we're very grateful to them. So, matters vital to Canadians, that's what we're all about, and conversations about our healthcare policy, the health system, and the future is certainly a topic that affects every single Canadian. Here is how the Walrus Talks works. You each have a program in your hand. We leave the lights up. The front of the program, the speakers are in speaker order. Their bios are on the back. I am not going to come up in between each speaker and read the program to you. We expect that you can and will follow along. You will see and hear 7 speakers in a row. Each talker has 7 minutes each. They know this. And so a little over 49 minutes from now, I'll be back up here, and then you can join us and them at the post-talks reception. So just before I let them get underway, I would like to thank each in advance. So thank you to the founder and managing director of Catalytic Health, Rohit Khanna, the president of the Canadian Foundation for Healthcare Improvement, Maureen ONeal, the jurisdictional lead of Closing the Circle of Care Expansion Project, Karl Mallory, the co-founder and CEO of Eve Medical, the industrial designer Jessica Chang, forensic pathologist Dr. Kona Williams, who is Canada's first and I think only First Nations forensic pathologist, the Canada Research Chair in Breast Cancer, Dr. Stephen Nayrod, and the co-founder and CEO of Deep Genomics, Professor Brendan Frey. Thank you all for coming. Let us begin.
Well, good evening, and thank you very much to everybody at the Walrus. And of course, thank you to our partners at McKesson for engaging this room in this important national conversation. My name is Rohit Khanna, and it is a pleasure to be here tonight. So my background, just so you know and so you have some context, is in health economics and epidemiology and public health and health policy. And so I come at the topic of innovation from this perspective. So with that said, I'm going to spend the next 6.5 minutes talking to you about non-traditional innovation in healthcare. And I'm going to talk to you about why I'm so excited about it, why I'm hopeful about it, but I'm also going to talk to you about what keeps me awake at night and why I'm scared when I think about non-traditional innovation in healthcare. So with that said, this is our traditional view, of innovation in healthcare. And it ought to be our traditional view because scientists working in a laboratory with pipettes and petri dishes looking through microscopes is what clinical and bench research is. And that's what drives traditional innovation in healthcare. But tonight, I want to talk to you about non-traditional innovation in healthcare. And so what do I mean? Where is that taking place? Well, it's taking place where everything else is taking place, which is social media. So let's start with Facebook as an example. Now, Facebook is working feverishly and aggressively to modify and reinvent their algorithm so that they can pick up user-generated content that will allow them to understand adverse events and side effects, a concept known as pharmacovigilance. And Brendan's going to talk a little bit more about deep learning and algorithms a little bit later this evening. So this is really innovative stuff. This allows Facebook and their team of engineers to be able to pick up user-generated content, be able to code it, analyze it, and spit it back to us in some meaningful way. And so what happens is when you go and take your high blood pressure medication and you feel a little bit nauseous, or you take your biologic for rheumatoid arthritis and you maybe have a little bit of redness on your skin, you don't really do anything about it. And then you go on Facebook later in the evening, because that's what you do every evening, and you update people on the status of your life. And you might innocuously mention that, oh, I'm feeling a little bit nauseous, or, I've got a little bit of skin redness. Well, that is, as I said, what Facebook is trying to harness. Now, what's the problem with this? Why should we be kept awake at night? Well, like a good epidemiologist, I worry about association versus causation versus confounding, meaningless noise. How do I know that the high blood pressure pill you took and the nausea that you're feeling is because of the pill? What if you took the pill and you went on a long car ride without your glasses and decided to read a book? What if you injected yourself with Enbrel or Humira for your rheumatoid arthritis and then decided to go sunbathe in the backyard and you got a sunburn? So these are challenges. These are things that keep me awake at night when I think about non-traditional innovation in healthcare. Now let's talk about Dr. Google. So, as we all know, Google is doing a tremendous amount in healthcare, probably stuff that you and I don't even have visibility on. But what I want to talk about tonight is their core product. I want to talk about their search engine, because we've become so used to this search engine that we don't think it's innovative anymore. It's just run-of-the-mill. Well, I'm here to tell you, and again, I'm going to put Brendan on the spot because he's going to refer to this later in terms of algorithms and deep learning. The core of Google engineers work tirelessly every day, and I don't feel sorry for them, they've got a great stock price, but they work tirelessly every day to contextualize and bring relevancy to your search queries. Google 10, 12, 15 years ago is not the same Google it is today. And why is that important? Why is their core, mundane, run-of-the-mill search engine important in terms of non-traditional innovation? It's important because we know that health literacy is strongly associated with positive health outcomes. There's no debate around that fact, and I'll be more precise. We know that people who have higher health literacy have less hospitalizations. We know they use the emergency department less. We know they are more likely to get vaccinated, they are more likely to get mammograms, and in seniors, there is a statistically significant association between health literacy and reductions in morbidity and mortality. So it's important. And the work that Google is doing is tremendously innovative, even though we get on our computers every morning, open them up, and we don't take a second thought about that search engine. But why do I stay awake at night? Well, for one, upwards of 50% of online health information is either incomplete, incorrect, or purposefully misleading. And so we need to do a better job of adjudicating, validating, and authenticating online health information. And the second reason I stay awake at night is for this slide. It's because Jimmy down the street, or Bobby, your neighbor, is working on a psoriasis treatment in his basement. And through the magic of search engine optimization, he can ensure that his product vaults to the top of a search query. When paid search supplants organic search, we have a problem. Because when you skew search query results, you skew health literacy. And when you skew health literacy, you skew health outcomes. Finally, I want to talk about our favorite rating site, Yelp. So it's fun to rate a restaurant, it's fun to rate an airline experience or a hotel. But what's so innovative about rating a doctor? Well, if you believe that quality signals drive demand, and you believe that demand drives access to care, and you believe that access to care has a trickle-down effect on the allocation of scarce healthcare resources, what Yelp and sites like Yelp are doing is incredibly impactful in the way patients select and access care. And we've known this for years. We've seen slides like this for at least a decade. In fact, this slide is 9 years old. We know that more and more people turn to the internet and to friends and family when they make a choice in selecting a primary care physician. This is no surprise. So why do I stay awake at night? Well, I stay awake at night because it's one thing to rate the decor of your doctor's office or rate the parking or the snarkiness of a receptionist, but it's another thing to rate a doctor's clinical ability. If you don't risk adjust a doctor's practice, you can't really make an apples-to-apples comparison between two doctors. Maybe one doctor is always running late and disorganized because he or she is seeing the toughest cases, the worst cases, the train wrecks, the people that nobody else wants to see. But you can't get this across on a site like Yelp or other sites. So that's why we need to be careful. So as I close tonight, let me just say this. I know we've barely scratched the surface on non-traditional innovation in healthcare. And I know we didn't even talk about Twitter and Instagram and YouTube and mobile health like Fitbits and smartwatches, but they too are reshaping and reinventing healthcare non-traditionally. But I remain hopeful. I remain very hopeful based on what I see. And when I remain hopeful, I think of what Douglas Adams, the British author and playwright, said when asked about innovation, and what I think we'll all be saying in 20 years. I may not have gone where I intended to go, but I think I ended up where I intended to be. Thank you. Good night.
Good evening, I'm Maureen ONeal. Canadians love Medicare too much. Twice as much as hockey, 3 times as much as the Queen, although the new engagement may change that. Tommy Douglas tops the charts as the greatest Canadian because of his conviction and political courage in removing income as a barrier to health care. Canadians look south and have a sigh of relief and feel pious that we don't have millions of our citizens with no health care coverage at all. Our love of Medicare, its status as an icon in our national mythology, is a barrier to making necessary improvements. Its status as an icon has frozen in time how we organize services, who actually provides care, and which services are covered. Compared to other developed countries, we are ranked close to the bottom, right at the bottom, in the time it takes to schedule an appointment with a specialist. Why is it so hard to change? Let us step back to the late 50s when the CCF government, led by Tommy Douglas, was designing a new health system. Saskatchewan wanted good connections between GPs and specialists with public health and social services. There was even talk of community boards to ensure patient and community involvement and feedback. Unfortunately, an election was coming. Many doctors were already opposed. Given this opposition, Tommy Douglas's cabinet were worried that this fundamental reform would be lost if they tried to sell the whole new approach. Instead, cabinet agreed government would insure everybody so that people didn't have to pay for doctors' visits. Hospitals were already covered. Left aside was the dream of creating an unbroken continuum of care. They settled for a payment system, not the well-connected system of health that they wanted. This dramatic backdown did not save the day. Doctors went on strike anyway. The strike was settled by government agreeing to leave management of health care in the doctor's hands. This compromise did mean that people's incomes were no longer a barrier to doctors' care. However, there was no coverage of dentists, physiotherapists, psychologists, drugs, glasses. When the federal government brought in Medicare in 1966, all provinces eventually adopted the Saskatchewan Compromise. Private insurance through employers, particularly large employers, looked after care not covered by Medicare. Unfortunately, at least 30% of Canadians don't, and did not at the time and don't now, have those benefits. They must pay for these health services and drugs, not much different than America. However, it is much different than European countries. This is the main reason why we fare so badly in international comparisons. It's not what we have, it's what we don't have. It isn't efficient or even the most appropriate care to have only hospitals and doctors' visits fully funded. It's inefficient not to cover drugs, to have patchy access to affordable home care and nursing homes, to make it hard for people to see a psychologist or a physiotherapist. And it's definitely not good care when people with mental health or addiction problems have to wait months for treatment unless there is a dramatic crisis. I said at the beginning that it's possible, indeed even probable, that because Medicare is our number one love, tampering with it exacts a huge political price. With the exception of our former health minister, the Honourable Jane Philpott, most ministers are reticent about saying to their voters that we have problems, that we could do much better, that there's lots of room for innovation and improvement. Staying the same, with at least 40% of every province's budget spent on healthcare, means we will be starving income support, education, housing, social services, the very kinds of supports that are important for good health. Curiously, there is little discussion of why our healthcare is so much less safe, for example, than the Dutch. Provinces have tried to improve healthcare by creating regional management structures like the local health integration networks in Ontario, through various financial incentive payments to doctors, joining with the Canadian Institutes of Health Research in supporting patient-oriented research. We have had limited success in improving performance. We are still near the bottom of the charts. The definition of medically necessary to encompass non-doctor, non-hospital services remains unchanged. Too frequently, there are standoffs between a province and their doctors, as we see in Ontario. The technology revolution, and we'll hear lots about that tonight, has huge potential to give more control to us as citizens and patients to manage our own health. Is anybody here becoming an obsessive step counter? The sky is almost the limit. We see it in action in post-operative follow-up, as the Ottawa Heart Institute has been doing. But email appointments with your GP? Not usually. Any innovation you can think of, and you're going to hear about lots of them tonight, any innovation you can think of is happening somewhere in the world. We need to not only create them in Canada, but bring them home to Canada, try them out. Change regulations to accommodate. Ottawa doctors, Claire Liddy and Aaron Keeley, they developed an e-consult service which dramatically speeds the connection between family doctors' access to specialist advice. And what that means is that it turns out that with the exception of about 25% of cases, the GP can actually handle it. This can be hugely important for people in rural areas. My organization helps healthcare organizations and hospitals spread and scale better ways of doing things. So that means that examples like Dr. Liddy's and Dr. Keeley's get spread across the country. So what do I recommend for our much-loved but underperforming Medicare? Make it easy for one province to learn from another. Support through regular health budgets the best local ideas of doctors, nurses, and other healthcare providers who are encouraging positive change. Put expansion of the coverage of health services on the political agenda. Dare to experiment with both private and not-for-profit providers as long as patients don't have to pay. Put patients and families at the center, which brings it back to us. No more unconditional love. We should have the quality of care that Tommy Douglas fought for. After almost 60 years, isn't it time?
Good evening. My name is Karl Mallory, and I work with Mustima Information Solutions and with Cowichan Tribes. And I'm very happy and excited to be here to talk to you tonight. I want to talk to you a bit about an opportunity that I believe exists for First Nations across this country to lead some transformative change in our healthcare environment. But first, maybe a little bit of background and a little bit of context. I'm sure we've all seen over the past months and years articles in our newspapers that speak to problems and challenges within First Nations communities with respect to healthcare. Now, I'm not suggesting at all that these problems don't exist, or that they don't warrant our attention, or that we shouldn't be doing something about them. My challenge with some of these articles is that, not unlike a lot of news we see, it's deficit-based, problem-focused. And based on my experience working with a lot of First Nations communities across this country, I don't think it really speaks to some of the strengths that I've seen in some of these communities, especially in their healthcare models. Also, I don't think these articles, not that they're intended to, but they don't really build a sense of understanding about the healthcare system on reserve and how different it might be from what most of us would experience when interacting with provincial services. I've been fortunate enough in the past decade or so to spend quite a bit of time working with First Nations directly, on reserve, in the health centers, and I've had a chance to really learn and listen to what's going on in these health centers. Long ago, I was asked to basically just go out and listen. If I wanted to actually work in this environment and try to do something meaningful, I should go out and learn what's actually going on. And I need to do that by sitting down, maybe having a cup of tea with the health director and the nurses, and actually gaining an appreciation for how they're delivering care and what kind of challenges they have before them. So I did that, and I've been across the country to many, many health centers. I've been to big health centers. I've been to some really small health centers. I've also discovered an appreciation for how heavy a truck can be in the middle of winter when it breaks down on a logging road in northern BC. And I have, unfortunately, flown in some pretty terrifying little planes to get into some very beautiful communities, but they're hard to access. And what that's also helped me understand is that they can be hard to get out of when there's a health emergency, or when you're seeking care that may not be provided within the health center that you have available to you. Invariably, though, what I have seen is a very dedicated group of health professionals working in these health centers in a very coordinated manner with their community's best interests and priorities at the top of their mind. They're often working in situations where they don't have enough capacity. Their funding models can be confusing and hard to interpret. And of course, there can be challenges accessing the kind of specialties or capacity or specialists that they need. But let me ask a question. How many people have been to a First Nations health center? Good. So those of you who have will understand that the care model there is not fee-for-service. It is not based on primary care or acute care. It's mostly based around community health, public health, prevention, and promotion. But what's most interesting to me is that these services are provided in a very holistic and integrated manner. There's a high degree of coordination within these health centers, and at the center of the service model is the patient, the family, and the community. And the providers there are doing everything they can with limited resources and usually without any health information management technology at their disposal to deliver these care services. Cowichan Tribes is the largest First Nation in BC, and I've had the good fortune to work with them for close to a decade now. They have been early leaders in the adoption of health information technology that is focused on supporting the First Nations care model. They're also guided by a set of teachings that are delivered by their elders. And these teachings really permeate everything that's done in the community, particularly in the health environment. I've been fortunate enough to have these teachings conveyed to me, and some of them really resonate with me, particularly in the context of health. This one in particular, going back to what I was saying earlier about the care model and the patient being at the center. But the other one that's interesting, and I think very important and timely, is this concept that each person has a responsibility for their health. I think that's probably more broadly applicable than just in a First Nations context, in fact. To me, it conveys that we all have some sense of obligation to take care of our health, to make good decisions, to advocate for ourselves. Well, the folks at Cowichan Tribes really understood this and agreed that if to do this properly, we have to give the patients tools. How about 21st century tools that allow them to fulfill this responsibility? So another question maybe. Who today in the audience has electronic access to their health records? Wow. And who can communicate electronically with their healthcare providers? Wow. Okay, who would like to? Yeah, it's not rocket science, is it? Well, Cowichan Tribes, in partnership with Canada Health Infoway and McKesson Canada, and leveraging their Relay Health tool, have developed the Mistema Citizen Health Portal. What this allows is for community members in Cowichan tribes today, this isn't theory, this is happening right now, to access their health records electronically, to contribute to them, and to interact electronically with their providers in the health center. In addition, those providers can send information to the portal that they're documenting in their clinical information systems, and conveniently, the physicians in the local environment can do the same, enhancing a continuity of care model where information is flowing between the providers and the patient is at the center of the circle of care. There's also a stream of laboratory and pathology results coming from Life Labs into the portal. What this has essentially done is implement a care model where the patient is front and center. The patient is involved in decision-making, there's secure online messaging between providers and the patient, and there is a circle of care that extends beyond one facility. It allows providers that constitute that circle of care, even if they're in different practices, to communicate for the benefit of that patient. What we're hoping is that as this technology, as this model spreads and scales to other First Nations, which it is doing now, that you'll start to see more positive news in the environment about how First Nations are perhaps transforming some of the thinking about patient access and circle of care models, and being always mindful of the teachings of the elders and Cowichan tribes. Having gained experience in this area, we are always happy to share what we know in the hopes that, in fact, this model could spread to the rest of our healthcare system. Thank you.
Hello, I'm Jessica Chang, and I'm going to talk to you tonight about innovating in healthcare, the Women's Health Edition. So I'm curious to know how many of you in this room know the name Margaret Crane? Okay, not a lot. Second question, how many of you know, even as a passing acquaintance, a human baby? Okay, good, lots of you. Well, I'm willing to bet that the existence of 80% of those babies that you all know was first detected using a home pregnancy test. Margaret Crane was the woman who made that home pregnancy test happen. And what I love most about her invention is that no one today really thinks twice about it. It's totally ubiquitous, and it just makes sense. You test yourself until you get a positive, and then you see a healthcare provider who can confirm the test and help you from there. It's a simple, elegant, efficient solution for everyone. In fact, when my partner and I started to research non-compliance in cervical cancer screening as design students, we were inspired to create a system where women could screen for cervical cancer at home, just like the home pregnancy test. This type of system tends to be what we imagine as good innovation in healthcare to be like. Solutions that are quick, cheap, accurate, and frees up resources. Well, Margaret first proposed her idea for this test in 1967, and even though it eventually became a commercial success, it almost didn't exist, and it took a decade for this product to get out to market. Well, tonight I thought I would take a look at some of the challenges that Margaret faced when developing the home pregnancy test and compare that to challenges that we now face in developing a home HPV test, two home screening products for women developed 50 years apart. So challenge number one, changing culture. Back in the 1960s, it was the norm, as it is now, that doctors were in charge of anything healthcare related. When the home pregnancy test was first introduced, it was met with resistance, not because it was a bad test, but because it simply was not the way that things were done. In some ways, this is actually still the case today. We still have a culture of sticking to what you know, including the fact that healthcare is largely clinic-based. Even though 15.5% of Canadians don't have a family doctor, and 30 to 35% of women don't screen for cervical cancer regularly, there isn't really much of an alternative other than just going to a clinic. To really embrace the many opportunities for innovation in early diagnostics and preventative care, things that are cheap, fast, accurate, and free up resources, we need to adopt a mindset that healthcare can happen at home, and at the very least for those who wouldn't otherwise be able to access it at all. Challenge number 2, trusting patients with information. A common concern about the home pregnancy test was that women would not be capable of following instructions to complete the test, or of handling a positive result on their own without a doctor present. The idea was to ensure a safety net for women who may become hysterical upon learning that they're pregnant, and to stop them from making rash decisions like getting an abortion or jumping off a bridge. Nowadays, we talk less about hysteria and jumping off bridges, thankfully, but we still don't fully trust patients with information about their health and to make informed decisions. In the process of our development, there were certainly those who felt that women should not be able to receive their HPV test results if it was positive, unless they could talk to a doctor, preferably in person. And like the pregnancy test 50 years ago, the driving force behind this idea is that it would cause unnecessary anxiety and stress. While a wave of pregnant suicides did not happen in 1977 when the test came out, and today test results is information that patients have a right to, and it's information that they want to know. It's also information that drives them to seek education and to learn more and be informed when they talk to their providers. Challenge number 3, collaborating with outsiders. In the 1960s, Margaret struggled to win over people within the system. When she brought the idea of a home pregnancy test to her managers, they balked. They were terrified of upsetting the apple cart, and doctors were not on board. Even though she had firsthand experience with distressed friends that she knew could benefit from this test, her suggestions were dismissed as not advisable or unfeasible. And when a company executive finally decided to give the idea a try, Margaret herself, as an outsider, a woman and a designer, had to force her way into meetings that she was not invited to. As a designer in healthcare myself, I'm aware of the fact that I am also an outsider. People are often surprised and confused about how I got into this in the first place, and sometimes are a little bit skeptical. But being an outsider was part of the reason of why Margaret came up with this idea in the first place, and more importantly, she cared enough to keep plugging away until it happened. So looking back, while there has been a lot of change over the last 50 years, many of the challenges to innovating in healthcare remain somewhat familiar. But what also remains is that there is still an incredible opportunity for tenacious innovators and their partners and champions to improve the system that impacts us all. So to close, I'd like to share a few ideas on how I think we might be able to better support innovation in healthcare so that 50 years from now, this talk will be very different for the innovators of the future. Idea number 1. Innovation is not just for innovators. I think that if everybody who worked in the healthcare system actively sponsored 1 or 2 ideas they thought could improve their field of practice, we would see an explosion of good solutions and more openness to new ideas. This would also build a culture of innovation across the healthcare system. Idea number 2, patients are a treasure trove of innovation. Patients, the end users of healthcare services, can be an incredible guiding force for discovering new solutions that we may not have thought of before. Idea number 3, there is urgency to innovate and adopt. I know that 1 woman a day dies of cervical cancer, and that since we started our project, roughly 2,200 women have died of a preventable disease. Keeping metrics like this in mind help remind us that there is a human cost to time, and it's up to us to push forward, innovate, and adopt with the urgency that it deserves. It goes without saying that Margaret Crane is one of my heroes for changing women's health and having the perseverance to do so. My hope is that this talk has inspired you to support a healthcare innovator or become one. who is working on their own simple, elegant, efficient solutions that at some point in time in the future, no one will think twice about because it just makes sense. Thank you.
Good evening, everyone. I am Kona Williams. I see dead people. Not only do I see them regularly, it's my job to understand them. Dead people can't speak to us the way that I'm speaking to you right now. They have a very special language, one based on careful observation and very keen interpretation of medical and scientific facts. Using this information, I'm able to piece together a story, one of the truth and death, a story as unique to each person as they were in life. I am a forensic pathologist, and I'll answer the first question preemptively that I invariably get. It is not just like CSI. It is much better than that, and for people like me, it is infinitely more interesting. I'm a subspecialist physician. I perform autopsies. I order and interpret tests just like any other doctor. I write reports, and I testify in court as an expert witness in my field. It has taken me over 14 years of post-secondary education to be able to do this. Autopsy. The image that comes to mind for most people is that of a dark basement room in some hospital, lights flickering for a dramatic effect, a dead body opened up on some metal table, various body parts sort of out for display, pools of blood, creepy folks with shiny steel instruments that are glinting off of thick glasses. Death is frightening, and death is mysterious. My reality is very different. The autopsy of the 21st century is changing. It is changing because of technology. I'm going to show you some of the technological wonders of my field, from using specialized post-mortem images to the molecular genetics of the autopsy of the future. This is a CT scan of the head and neck. The image has been rendered using powerful computer programs, subtracting away the flesh to show only the bones. This person died from blunt impact head trauma. I know this because I can see the shape of the skull, as can you. And if you imagine an egg being dropped on the floor and the shape of that egg after it's been dropped on the floor, this is why you can understand why we call this an eggshell fracture. Sometimes this is very obvious, but the human body is incredibly resilient, and what we observe on the surface may be very different from what we see under the skin. Using post-mortem CT imaging, I get a sneak peek inside the human body before my knife even touches it. I can use these images as tools to guide my examination, to target specific organs, or to forego the scalpel altogether. CT and MRI are not common in forensic pathology today, not yet. I'm very fortunate to be working in the most advanced facility on Earth to be able to bring you these images. This is a very special CT image with 3D volume rendering. The little red dots that you see in the chest, this represents colorization of the highest density material, in this case, metal. This person died from multiple gunshot wounds. These images help me locate foreign projectiles in the body and retrieve them more easily, as well as aiding with directionality of the gunshot wounds. I use this just about every day. This is a standard cross-sectional CT image through the chest. Although the cause of death in this case is obvious without CT, for those of you who are wondering, there's a crossbow bolt right into the heart. This image shows the precise location of the arrowhead. And as you may imagine, it is much more palatable in court and digestible to the public eye. So I'm going to shift gears for a little bit. This is an open human heart. To my eyes, this heart is very abnormal. In the past, the cause of death might be dilated cardiomyopathy. That would have spelled the end of the death investigation. Unfortunately, about 20 to 30% of sudden cardiac deaths in young people are not explained following traditional autopsy techniques. And as you can imagine, this left families with more questions than answers. Some primary diseases of the heart leave only microscopic changes in the tissue, requiring subspecialty trained eyes to diagnose them. Others leave no structural damage at all, and therefore make it difficult for even the most experienced pathologist to pinpoint an exact cause of death. With the advent of a molecular autopsy, advanced techniques in DNA sequencing, such as whole genome sequencing, allows a large number of genes to be screened for possible mutations. This sharpens our knowledge and our vision to the molecular level, which is far beyond what we see under the microscope. Today, this heart would be examined by a cardiovascular pathologist. DNA would be sent for genetic analysis. The results would be discussed and evaluated by a panel of experts of specialists. If there was a mutation affecting the heart that could be inherited, the surviving family members would be offered a referral to a cardiologist. The molecular autopsy is saving lives. Now, the molecular autopsy does not need to be limited just to the heart. This is only exposing the tip of the iceberg. There are many more other diseases that have baffled physicians and scientists for decades, such as sudden unexpected death in infancy or sudden unexpected death in epilepsy. These diseases may one day be explained using the molecular autopsy and in turn save even more lives. For now, death continues to hold many secrets, but they're slowly being unraveled and exposed to the light with new and evolving innovations in both science and medicine. Death still has much to teach us, and it has much to teach me. And it's not only about life, but also about ourselves. I want to thank everybody for your attention. Merci, nyawa, miigwech.
Hello. I'm Stephen Nayrod. I'm a doctor and a breast cancer researcher at Women's College Hospital in Toronto for 22 years. When I arrived at Women's College in 1995, we treated breast cancer, most women with breast cancer, with lumpectomy. Removed the cancer and a bit of the surrounding breast, but left the breast intact. This operation became very common because of a blockbuster paper in 1985 showing that the death rate of women treated with lumpectomy and with total mastectomy were about the same. And so we adopted that as a standard of care. What's surprising is in the last 10 years, we've seen a shift from lumpectomy to many women are getting, and you've heard of it in the news, bilateral mastectomies. Both breasts are being removed for the treatment of a single breast cancer that could be managed by a lumpectomy alone, by breast-conserving surgery. Why are a third of women getting this operation? So I get asked, I look at individual patients' decisions, surprising decisions, and then I go back to the charts and the data and looking at patterns, which I've collected in all the patients at Women's College Hospital over the past 25 years. Why are these choices being made? Who's to say it's the right decision, and whose decision is it? The patient, the doctor, or the healthcare system that's paying the bill? Now, we're talking tonight about personalized medicine. In 2012, I think we entered the field, the notion of personalized medicine, whereas each individual as a patient, we could break them down the risk on a personal level rather than yes or no. We could even give numbers from 1 to 100 describing an individual's risk. Around 2012, I asked, is this really a good idea? Is this going to work? We're hearing from other speakers tonight. In other words, is the information that we give to the patient meaningful for them in the same way information is meaningful for the doctor. And in 2012, I got my first surprise. This was in 2008, at Women's College Hospital, we offered genetic testing to all Jewish women for practical reasons. Now we offer it to all women. And at that time, based on this advertisement, or this free advertisement in the Globe and Mail, we had 8,000 women come to Women's College Hospital on Bay Street, take us up on our offer. Now, this was for BRCA1 and BRCA2. Some were given a positive test, some were given a negative test. The women that were given a positive test, we told them, you have a 20% risk of ovarian cancer. Furthermore, we said the best treatment for that is having your ovaries removed. The women we gave a negative test, we said you have a 1% chance of ovarian cancer. There's really nothing we recommend to do about that. Now, a year later, being diligent researchers, we called them back and asked them a couple of questions. What do you think your risk of ovarian cancer is, and what did you do about it? Well, the good news was the women who had a positive test, they estimated their risk to be 20%, and diligently they had gone to their doctors and had their ovaries removed. Then we asked the women with a negative test what they thought their risk of ovarian cancer was, and they said 20%. But none of them had had their ovaries removed. They both interpreted 20% as different. One was a positive test requiring action. One was a normal result requiring nothing but, which is reassuring. Second example, 2015. We did a very large study, got a lot of press, on ductal carcinoma in situ, or DCIS, was published in JAMA. And in that paper, we showed that the risk of dying of breast cancer after this ductal carcinoma in situ, which is an early or a precursor lesion, a very early form of cancer. And we showed that the risk of dying in 20 years of breast cancer for women with that diagnosis was 3%. Now, someone considered that reassuring, but other women considered that, oh my gosh, and ran off and had a bilateral mastectomy. For these women, the 3% encouraged them, was a signal that they needed surgery and they had to have their breasts removed. Now, if we go on the streets of Toronto and ask the average women what you think your risk of dying of breast cancer is, most of them will say greater than 3%. But for them, that's not an ominous number. It's just a number that they feel they could live with and move on and go along their way. I don't think it's the numbers that count. I think it's the idea of being told you have a positive test or a negative test. And even when we use a personalized medicine approach and we give them a number, precise number between 1 and 100, they'll say to me, well, doctor, but is that positive or negative? Third example, or which relates to a second question. What is our goal? The goal of the doctor and the goal of the patient, and are those the same? Is it to prevent, I'm a cancer doctor, so I say, well, you know, we want to prevent primarily death from cancer. We also want to prevent cancer and we want to alleviate cancer worry. But which of these are the most important? All three are relevant, but by generating worry about cancer, we may be creating a new generation of worried women. Now let's consider a woman in 2017, a young woman with breast cancer. I told you before, they would have a unilateral lumpectomy. It was the standard of choice until recently. And now they say, doctor, the doctor says you could have a lumpectomy. This is the least invasive surgery and has the best chance of survival. The patient says, yes, I want to have a mastectomy. I want to be there for my children. What she really means is that, yes, but I'm having this anxiety about a new cancer every day, and what I really want is the relief of that pressing anxiety. And by having a bilateral mastectomy, it's going to take away the worry of ever getting another cancer. So which of these is the most important? Now, consider this. This is very interesting. So I work in Poland in the summer. I spend a month every year in Poland running a big cancer research program in Szczecin. And what we find is really interesting is that young women under 40 with breast cancer in Poland do better than they do in Ontario. Interesting, surprising, but moreover, we find that the Polish women almost always have chemotherapy and tamoxifen, whereas the Canadian women, it's often less. Why is that? Because we've developed this concept that choice is paramount in the patients. It's the right choice. I'm not saying it's not. I'm just saying when we introduced the concept of choice in Canada, which is progressive versus in Poland where it's still paternalistic, we see that many women are given the choice as well, I'll choose not to have the therapy. There are consequences to that. And I'd just like to finish up. This was a drug that was introduced for breast cancer and was a big article, I can see November 2017, was described as new hope for women with breast and ovarian cancer. Now, if you see the article, you'd say new hope against a lethal form of cancer. You would assume that that reduced the number of deaths or even extended the lifespan. But in fact, it doesn't. It delays progression, but doesn't affect the lifespan or cure the patient. When I pointed that out as the sole dissenter, actually, in the New England Journal of Medicine, I said, I think it's disingenuous for the drug companies and the journal to promote this drug as one that saves lives, because it doesn't. It was really met with a mixed reaction from my colleagues. In fact, I was kind of surprised, to end on this note, but one of the patients said to me, well, doctor, after reading my article, I ate my breakfast and went back to bed. The day had just begun. I wish you would remove your treatise from the internet. It serves no purpose except to dash the hopes of thousands of women around the world. Don't steal my hope, doctor. It's all I have. So I don't have the answer to these questions. We certainly want to be able to offer the best hope is a quality of life and for our patients, but we also have to raise the question as a society, as discussed before, is it in the interest of the Canadian to offer drugs that don't really work in order only to increase the well-being in terms of the hope of the patients? It's a difficult question I think we all get to face. But just to summarize over time, I think, I really changed my way of thinking at Women's College over the last 25 years and starting to think more about some of these decisions we make. Who should be making the decisions? Is it always wise? Should we have more impact from the government, federal and provincial, in helping us guide our way? But moreover, I think it's very important to capture these stories of the women with cancer on an individual level, and also to document them and to be able to keep track of them in order to make the best use of the information and to guide us in our choices in the future. Thank you.
Good evening, everyone. My name is Brendan Fry. I'm a professor, an entrepreneur, a scientist, and an engineer. Tonight, wonderful talks, by the way, preceding me. And we've heard a lot of condemnation of human intelligence and also uplifting stories about the promise of new technology. And what I'm going to talk about is my belief that artificial intelligence is going to unlock a new universe of medicine in the future, and it will be a game changer. So first of all, a couple minutes on artificial intelligence. What is it? So the most common one that people probably know about is voice recognition on their cell phone. You speak into your cell phone, and the cell phone recognizes the words, right? That's an example of artificial intelligence. What many of you may not know is that the recent breakthroughs in artificial intelligence were made possible by a field of artificial intelligence called deep learning, and that was pioneered in Canada. And so Rohit earlier talked about Google and Facebook, and the fact is that the lead scientists, the top scientists at those places are actually from Canada. People like Jeff Hinton and Jan LeCun, who studied here in Canada. Other people like Yoshua Bengio. And I myself worked on this field of deep learning in the 1990s. So that's something that we should celebrate, is that this new area of artificial intelligence is largely due to Canadian innovation. Now, we already know that AI makes a big impact on ourselves through our cell phones, but it will change all aspects of society, from farming all the way through to medicine and many other areas as well. This is recognized at various levels. Justin Trudeau has been talking a lot about artificial intelligence in the last few months. I met with him a couple years ago to talk about the importance of AI in Canada. Eric Schmidt, the chair of Alphabet, of Google, met with the Prime Minister a couple weeks ago for a public discussion on the topic. There have been a lot of discussions about AI in Canada, so keep your eye on it. Now, let's talk about medicine. Medicine is broken. I think we all know that. We've heard today about these wonderful technologies that have been innovated and developed in the last 20 years, from MRIs to genome sequencing to even more recently gene editing, the ability to change your DNA, change the code that governs your cells and governs your health. However, I think most people would agree that the health benefits have fallen way below our expectations. We've heard a couple of people talk about that tonight. So what's going on? Let's look at one example, genome sequencing. Genome sequencing will soon cost less than a trip to the grocery store. So we'll be able to read all 3 billion letters of your DNA, the A, C, G's, and T's, just 3 billion letters that make up your DNA. But what can we do about it? Can we accurately detect disease? Can we develop treatments for disease? And the fact is, the tragic truth is that there's a giant gap between our ability to measure your DNA and our ability to act on it. I refer to that as the genotype-phenotype gap. So what's going on? What's broken? Think about medicine, think about your personal experiences with medicine. Maybe it's going to your family doctor. You'd go to your family doctor, you'd say, I have these symptoms. Your doctor might say, well, it could be this, let's do a couple tests. Okay, and then you go off and a couple months later, you've got the tests done. We're moving into a completely different era of medicine, one that's data-rich and information-rich. Each of you already has a lot of information about yourself, whether it's from your Fitbit or perhaps from a genetic test, or perhaps you've submitted a sample to 23andMe, or maybe had your genome sequenced. So you'll have a rich source of information about yourself, and also society has a lot of information which helps us understand what's going on. And so it's an information-rich and a data-rich situation, a situation which this old try and see approach to medicine is really ill-suited to dealing with. So what's the solution? Well, the only technology we have that's capable of scanning through huge amounts of data and finding patterns that can be used to make accurate predictions is artificial intelligence. And that's what leads us to the thesis of my talk. And really, this transition I talked about in medicine is reflective of something completely new in history, really, that our ability to measure our biology and change our biology, alter it, think about DNA editing, has far surpassed our ability to understand it. No biologist or no group of researchers will ever understand the complexity of biology that's needed to identify a mutation and find a therapy that's highly effective for an individual. So really, when it comes down to it, it's not possible, really, to imagine a future in which AI does not play a crucial role in medicine. So let's come back to, Kona talked about genetic testing. So in my group at the University of Toronto, and more recently in our spin-out company, Deep Genomics, we developed AI technologies that can allow us to look at one of your mutations and make a prediction for whether it's a pathological mutation. When we compare our computer system to the very best human pathologists, our computer system agrees 95% of the time. What's interesting is if you compare 2 human pathologists from 2 different clinical labs, which you may have submitted your sample to, they agree between 50% and 75% of the time. Now, I think, and based on what I've heard tonight, I think what we need to do is focus on coming up with not just ways of detecting disease, but treating disease that are highly effective. So no more of these treatments that are wishy-washy, just a little bit better than random chance, or highly inconclusive. We need treatments that really work, 100 times better than these sort of wishy-washy stuff that's out there, the snake oil. And so that's what I'm focusing on now. That's what my company, Deep Genomics, is focusing on, is using our artificial intelligence technology to find treatments for disease. So over the next 2 years, we'll be using our AI systems to scan a vast space of about 69 billion molecules and identify within that space about 1,000 molecules that allow us to carefully adjust cellular chemistry so as to develop new therapies. And I'm going to finish my presentation by making a speculation about the future. We will get better at manipulating our DNA to achieve desired outcomes. That's going to happen. So where will this lead? And I do believe it will actually lead to, and what we will witness in our lifetimes, is the emergence of humans with extraordinary capabilities that they've designed into themselves or their children. Thank you.
If you've ever had that smug feeling ever in your life of, I might be the smartest person in the room, I bet you don't have that feeling right now. I would like to, if you could all join me in thanking all of our speakers at once. Rohit Khanna, Maureen ONeal, Karl Mallory, Jessica Chang, Kona Williams, Stephen Nayrod, and Brendan Frey. As I may have mentioned at the beginning, this Walrus Talks thing that we do has become quite a thing. Tonight is our 88th Walrus Talks since we started doing them, which means, what's 88 times 7? Not you. There's over 700, I don't know what that is. There's over 700 7-minute Walrus Talks on our YouTube channel and at our website that you can watch whenever you're, Googling something else or whatever it is that you're doing. So lots of things there. You can just head to thewalrus.ca where you can also subscribe, although much cheaper and easier to do so tonight. At the reception, Catherine will sell you a year's subscription of The Walrus for just $25, which never happens. That's a very big deal. So please, and sign up for the newsletter while you're there. I would like to thank everyone at the Museum of Nature, Meg Beckel, Dr. Graham, everybody for having us here. I would like to thank everyone, Jean-Philippe, Darius, Joseph, Ravi, everyone from McKesson, Canada, for making tonight possible. Our local partner at the Hill Times, and our national partners Inspire, Shaw, Shirk, and AMIA Aeroplan. And at this moment, I would like the audience to stay seated while the talkers and our friends at McKesson and the museum stand up and go to the reception first. Bye, guys. See you in a minute. Thank you. Go this way. We're setting them free 45 entire seconds before I set you free so they can get a drink before you trap them in the front row and they can't move. And yes, please come to the reception. There is food and there is drink. It's in the beautiful glass box with the giant jellyfish called the Queen's Lantern. And there is food there. There is drink. You can also meet our digital editor, Lauren McKeon. Lauren, where are you? Loren, sorry, is right here. And she, if you've got story ideas, I am not your woman. Loren is your woman. She's an editor at the Walrus, so go and see her. And please, the next Walrus Talks in Ottawa is February 28th. It will be held at the Library and Archives, that beautiful building. And it is the Walrus Talks, The Legacy of Canada 150. What did we learn and where do we go from here? So please join us on February 28th. Thank you for coming. Merci, megwetch, good night, and safe home.